So I'm Dr. Fabiola Balmir. I'm a reproductive endocrinologist at Kindbody, Minneapolis. I'm board certified in both general obstetrics and gynecology and in reproductive endocrinology. It's a separate fellowship that we do after we've trained in all things having to do with obstetrics, delivery, complicated pregnancies, all things having to do with gynecology, urogynecology, oncology. We have training in that, and then we do an additional 3 years of research and dedicated training towards fertility and endocrine as it pertains to kind of fertility and hormones and how the brain and ovary communicate, how the thyroid comes into play. So we've got all of that specialized training, myself and my colleagues, to be able to give you the best picture, holistic picture of what may be happening as you're trying to conceive, right? That's what our focus will be. And so as being a member of Kindbody, I'm proud to say that this mission that we're on is to give fertility to all persons, right? Fertility care for all persons, no matter how you choose to expand your family. And we have proprietary technology that's given us incredible rates. Just last quarter, our clinic had a 92% pregnancy rate. That's incredible, right? And that's for all comers, all patients, right? We don't cherry pick our patients. We don't select out for certain weights or certain, we don't select out for certain demographics, and we certainly don't select out for certain egg reserves, right? These are all comers that were able to come to us and have these excellent successes, right? And we're very happy about that. And we want to be able to provide that nationwide for all patients. And we have a number of Kindbody locations to provide this care. And what's unique about Kindbody is that we work with employers oftentimes, where employers can provide these benefits that allow patients to have IVF cycles at extremely reduced cost out of pocket to them. So a patient can be endowed with like 3 IVF cycles completely covered, so that they can basically experience the opportunity to expand their families at little cost to them, little to no cost. Okay, next slide. Okay, so in terms of what we offer, what can we do? What does our fertility office have for you? We've got fertility assessments for all persons, right? We can offer semen analysis. If you're not sure where you stand, or you just want to learn about your fertility, maybe it's something you want in the future, maybe you're interested in egg freezing, we can do an ultrasound evaluation, and we can do blood work to assess what your egg reserve is. We have virtual and in-person consultations. I'm a huge fan of the virtual consultations. It's allowed me to expand kind of going out to other communities. I've applied for licenses in North and South Dakota, as well as having a license in Montana and Nebraska. So that allows me to visit these patients virtually, make plans. And believe it or not, it's quite easy for a patient to fly in wherever their location is, to have a procedure done for a day and then fly out and be monitored from afar. We work with your community gynecologist at the same time too. We have that opportunity. So I'd encourage you to take advantage of the virtual opportunities, or come to one of our personal locations and just see our office, right? Our offices are very unique and giving you a very comforting feeling when you come in. Also, you'll find yourself in a lot of our kind of art that we have in the office. It's really diverse art that caters to all parts of the population. It's really nice. We offer inseminations, right? Whether that's donor inseminations, or you have a partner or known sperm source, we can do those inseminations for you. That preparation is very unique in the sense that we have a trained andrologist, and we conduct a semen test where, a sperm cleansing test, I should say, where we'll take that sperm and spin it through centrifugation and separate out those sperm that are abnormal and concentrate to the perfect amount of sperm without, with very few non-moving or dead sperm or oddly shaped sperm, giving you that perfect concentration of sperm. We do that through our trained andrology team. We also have IVF. IVF at Kindbody is done on site, where eggs, sperm, and tissues are saved here on our site, in our storage units, where we conduct all of our insemination, injection of sperm into the eggs on site. You know, all of this is done where you get your retrieval. We also perform genetic testing of the embryos. It's something that we can offer for many patients, especially if you have a unique genetic diagnosis, or if you want to kind of reduce your chance for miscarriage, perhaps, right? That's another option. Or do gender balancing in your family, right? Select out the next embryo as being perhaps male or female, and you have the opportunity to do that. Of course, we offer egg and sperm freezing. We can do that for fertility preservation purposes, whether that's I want to save my eggs and sperm because I'm not sure what I want to do in the future. I may be changing gender roles, I'm not sure, or maybe I just want to preserve my fertility because I don't know if I want children or not, but I want that opportunity to think about it when I get older. There's also the opportunity for embryo freezing. I have couples that are not yet ready to start growing their family, but they just want to put some embryos off to the side until they decide when they're ready down the line. Excellent opportunity to do that. Of course, we cater to the LGBTQ plus community, right? Any and all services we offer, whether that's looking for a egg donor, a sperm donor, a gestational carrier, we have that. We have a special third-party team that caters to you and coordinates that care for you, from finding the lawyer that you need to the gestational carrier to assisting you with selecting which eggs from a lot that might suit your needs or the demographic that you're looking for. And of course, we have male reproductive health. I'm proud to say that Kindbody is partnered with Kind Man. That's our associated urology group, where our partners with sperm can now learn about, semen analysis, but more than that, even get blood work assessments. Scrotal ultrasounds are offered now, so we can give you that full breadth of assessment. No longer do you have to go out and find a urologist and search in the community and who do they recommend and wait to get that appointment. We offer immediate appointments through Kindman that are also virtual, and our urologist will fly in to see you, right, pretty quickly. We've done that pretty often. And when there are procedures that are needed, such as sperm extraction from the testicle if a man has had a vasectomy, and in that case, our urologist can actually fly into our office and perform that procedure for you before your partner would have their eggs retrieved, right? If that were kind of a plan in place, right? Other things for us to consider: we have home kits. I think this is a really, really convenient offering where we can do home tests for egg reserve. We can even do a home test for sperm. Ideal is always going to be in person for sperm, but there are home kits available for those of us that are far away or can't get to a clinic. And of course, this next column just talks about more of the support that we have. We've discussed the third-party support, but we also have kind of that wellness support for mental health, right? Extremely important for us. We forget about that in our journey sometimes, that this can be mentally taxing for us. So we have therapists, right? Therapists who can help you if you have a specific history of maybe recurrent pregnancy loss, for example, or even just fertility, general concerns and questions, right? I tend to tell patients, please consider taking advantage of this. It's not always that our girlfriends or our partners are great resources for kind of just sounding off about everything that's going on and what you're thinking. I like the idea of using a mental health professional to kind of help us work through a lot of these feelings and emotions that we have. Also, we have mental health for any postpartum history, postpartum depression that you may have had, or concerns that you may be dealing with or are still dealing with, right? And we have good associations with community partners as well. We have a nutritionist as well that can help you focus on health as it pertains to your PCOS, or maybe you're looking for a specific kind of more fertility geared, help me get towards those fresh fruits and vegetables. What should I be looking for in my diet? Supplementation I can consider adding, and any pregnancy and lactation needs for nutrition, we can also offer that as well. Okay, next slide. Okay. So fertility care is extraordinarily important, more than ever, and knowledge is a priority. I do like that aspect of the slide. I handpicked that one. Knowledge is a priority because I find more and more of us are informed when we go into our doctor's visit, right? I don't know, many of you may be very young, but I still remember the days where we would go to our doctor's office only to be told what we're going to do. Right? It wasn't necessarily a joint decision. You didn't have a lot of information going in, and you just had to kind of blindly follow the direction that your doctor gave you. We're a different patient today. Today, we are empowered with what we do in terms of our own, so to speak, research, right? People like to laugh and talk about Dr. Google, but I really don't mind that. It's a way of kind of getting information for yourself and kind of presenting what concerns you may have to your physician and talking about it at that level, right? I've heard about this. What about my progesterone? I've heard that it could be too low. What does that mean? And even if it may be that question may not have all of the information behind it, it sparks a conversation between yourself and your physician where you can begin talking about, well, what is progesterone? This is what you should understand about it. This is where your levels are. And this is how it pertains to the overall fertility picture and why it's not typically measured at certain stages and why we don't typically administer progesterone, right? That conversation opens up. So I do welcome patients doing web searches. They're way more informed when they come into their visits. I think that's important. The biggest factor, right, is that we have to consider time. Time is essential for us as carriers of eggs or sperm, because over time, both the quality of eggs and the quality of sperm will decline. We'll talk about this in a little bit, but the quality of eggs will decline starting at the age of 35 precipitously, and the quality of sperm can begin to decline starting at the age of 40, right? And so those are all considerations as we plan our fertility journey. Next slide. All right, so let's first just kind of understand, how is it that we get pregnant in the first place? How does all this work? What are the things that can go awry that can warrant us to have to go to IVF? When should we start to consider it, right? First things first, we need an egg, an egg source. We need a uterus or house, and we need a sperm source to fertilize those eggs. Those are the main components, no matter where we get those sources from, but that's ultimately what's going to equal the end of our equation, which is a pregnancy or a baby. Next slide. All right, so as women, I say this spiel anytime I meet any new patient. We are born with all of the eggs we're ever going to have for the rest of our lives, and we're never going to make any more eggs than what we have. In fact, we start off at birth with about 400,000 eggs, and every day that supply of eggs is going down, and every day the quality of those eggs are going down. It's just a factor of time. It's totally normal that that's happening, but it's something to consider as we ovulate each month. Though we're only releasing one egg, we're also losing a group of eggs in that month and in that cycle. Next slide. Okay. How does one begin to evaluate what our egg reserve is, or even, so to speak, our egg health indirectly, right? We don't have a direct assessment for egg quality. Egg quality is best gauged by age. But in order to assess egg health, we can do certain labs and imaging studies. Those labs would include baseline egg reserve testing with FSH, which stands for follicle stimulating hormone. That's the brain hormone that's going to communicate with your ovary. Whereas in women who are in menopause or early menopause will have very high levels of FSH and low levels of estrogen coming out of the ovary. That's the brain shouting to the ovary, trying to get the ovary to put out more hormone, but it can't without an adequate egg reserve. And if you're in your menopause or perimenopausal, your ovary isn't capable of putting out enough of that estrogen. So we tend to see higher higher FSH levels there. The other level that we think about is anti-Mullerian hormone, or AMH. This is probably the most widely used hormonal test by reproductive endocrinologists. An AMH test is a way for us to assess how many eggs you have. Now, not specifically that you have 10, 14, or 300 eggs remaining, more of a way of saying you have a high number of eggs, a moderate number of eggs, very low egg count, or just a low egg count, right? And that helps us gauge how to approach next steps for you in terms of how soon we should start to tell you to start to try to get pregnant. So a normal level for AMH is typically a number that's 1 or 2 is a low normal to normal result, whereas higher levels for that would be a number that's 5 or greater. And AMH will not dictate the quality of the eggs. It won't dictate if you'll ever be in menopause. It won't even dictate if you'll ever be pregnant. But AMH will dictate the quantity of medication that we need to give you in order to release, instead of just 1 egg every month, maybe 2, 3, 4, or in an IVF cycle, 10 or more eggs to grow. And if you have a very low AMH, it would mean that you need high amounts of medication in order to get the ovary to grow more than 1 egg. And if your AMH is extraordinarily low, you may not respond to any medications. In fact, even giving you the highest dose of medication wouldn't yield a different result than your monthly cycle, which would just be the release of one egg at a time. And so when we think about telling patients to move sooner towards treatment or fertility treatment, one of the things we consider is that the egg reserve will get so low to a point where intervention may not be possible, and you'll just be dependent on natural conception at that time if you choose to use your own egg. Another assessment for egg reserve is an ultrasound. You can go with that next slide, Michelle. It works. So the next slide depicts a transvaginal ultrasound, excuse me, looking at the antral follicle count. AFC, or antral follicle count, talks about the number of follicles or eggs we can potentially grow in an IVF cycle. So I'm just going to use my pointer. So here, this is an ovary on ultrasound, and each of these dark circles represents a follicle in its very early stage. And inside of that follicle is a microscopic egg adherent to the wall of the follicle. The black area is actually just clear fluid. On a sonogram, it looks like it's black, but it's just clear fluid. And as you get stimulated in a cycle, these follicles will grow and grow and grow in size. We like to think of it as like a champagne bottle, right? These are follicles that will bubble up to the top, right, of your champagne glass, these bubbles that will bubble up to the top. And those will be the eggs that we're able to harvest at the time of retrieval, or if you're doing an insemination cycle, these are the eggs that will be available to us. So an antral follicle count in combination with assessing an AMH level, those two should correspond to one another. And I've always said this, right? We've always known this in medical school. Even a patient is never just one lab value or one assessment. It's never just that. You got to take into account the whole picture. What is that AFC and what is that AMH telling you? And if there's a huge gap between the two, a very low AMH but a high AFC, it should make you question what happened with that AMH. Was it conducted well? Was it left frozen because the specimen can degrade if it's not kept frozen? So other things to consider if you see a disparity between the results, but it should be, the results should reflect one another, so to speak. Okay, next slide. Okay, so we know about the eggs now. And so how are we even getting pregnant in the first place? Well, we talked about that process of ovulation, that FSH hormone is secreted by our brain, talks to our ovary, gets us to grow an egg and a follicle. That egg is released from the ovary, and it now is able to travel into the fallopian tube. And it's in the fallopian tube that the egg and the sperm will meet. Once they've met, that fertilized egg will continue to develop into an embryo to implant into the wall of the uterus, where you can see the arrow saying the embryo implants. Perfect. So this is coming into play for some factors that could go awry and why we may have trouble getting pregnant. Next slide. Okay. So starting at age 35, this is where we start to see kind of that precipitous decline in the quality of our eggs, right? Just a fact, right? Nothing we can do to prevent that. And for the record, there are no medications we can take, no injections, pills, otherwise that we can take, or teas, which is my mother was interested in, that we can take that can change our egg reserve. Our egg reserve is what it is when we are born, right? And it basically just depletes over time, right? Nothing we can do to stop that. And that process that's happening in our ovaries. And so there are 1 out of 10 women that will experience an extraordinary low egg reserve before the age of 40. We call that premature ovarian failure as well. And so we have to take that into account. And another reason why we want to screen women sooner rather than later, especially if you may have had a family history, perhaps your mom went into menopause in her 40s. I think that's another consideration for why you should consider fertility treatment sooner rather than later, or at least an assessment with a reproductive endocrinologist. Next slide. Okay. Quality versus quantity. Ultimately, it's always the quality that matters, right? And that's dependent on age, right? The biggest factor. A smaller quantity of eggs from a, let's say, 31-year-old woman versus a large quantity of eggs from a 44-year-old woman, it's more likely that that 30-something-year-old woman will be more successful with a smaller quantity because the quality tends to be better in those younger age groups. And that's something for us to consider as we talk about perhaps considering genetic testing to be able to determine how these embryos may implant, and possible pregnancy outcomes for us, risk of miscarriage, so on and so forth. Okay, next slide. Okay, so this slide I think is it's actually a really good slide. I remember seeing this some time ago, and it just depicts what we call aneuploidy as it pertains to age. Now, aneuploidy simply means abnormal number of chromosomes. An aneuploidy, for example, is Down syndrome. Down syndrome is having an abnormal number of chromosomes at location 21. And we'll talk about this even a little bit more as we get towards the slide on genetics, but we're all endowed with 23 chromosome pairs, and we can have any one of those chromosomes have an extra one or a missing one, and that may make us more prone towards miscarriage. Have that particular embryo, if it's missing a chromosome, be more prone towards miscarriage, or an extra chromosome be more prone to that, or genetic abnormality. And so what we're seeing on this slide is that as we get older, see, as these age groups are increasing, 35 to 37, 40, 42, greater than 42, there's an increase in abnormalities of aneuploidy, and there is a decline in the live birth rate, right? Abnormal chromosomes, a high number of abnormal chromosomes means a low level of live birth rates, right? Lower live birth rates. That's the correlation. There are more abnormal pregnancies from aneuploidy that typically lead to miscarriage or not getting a pregnancy at all. So that increases with age. We know that, right? Next slide. So other issues that can come about us not allowing the egg and the sperm to meet have to do with ovulatory dysfunction. And when we say ovulatory dysfunction, this is a big umbrella, right? That can fall under polycystic ovarian syndrome, which many of you may have been told you have. Polycystic ovarian syndrome is defined as having perhaps irregular cycles that take more than 35 days or less than 21 days to come about. It could be hair growth can be associated with that as well, or having a high number of follicles on your ultrasound. All these can be characteristics of polycystic ovarian syndrome that don't allow that egg to release regularly. Also, dysfunctions of our hormones such as thyroid and prolactin levels. When those levels are off, those can cause our brain to not communicate well with our ovary. And if we're not communicating well with the ovary, that means we're not releasing the egg regularly. So it's ovulation dysfunction. And then when we talk about hypo or hypothalamic dysfunction, that's simply discussing how the brain talks to itself to make sure those hormones are released to the ovary. And some of us are born with a deficiency in hormone to speak to that part of our brain that's supposed to talk to our ovary. And so in those cases, we can actually bypass those brain hormones and give you direct injections to stimulate the ovary instead, because the ovary itself is quite functional. It's just that brain communication that's off. And ovarian failure, we talked about this before. I prefer to call it ovarian insufficiency. And this is just that early menopause we were talking about, where our egg reserve runs out before the age of 40. And we're no longer having regular periods or no periods. And we have those high levels of hormones, and we won't respond to fertility medications that would typically help our ovary release more than one egg. So all those are factors of ovulatory dysfunction that your reproductive endocrinologist would evaluate and see if you meet any of those criteria. Next slide. So the next test to find out why the egg and sperm won't meet is to check the fallopian tubes and the uterine cavity. Right. This is great. This is a great picture. I grew up seeing this. My mom was a pediatric nurse, and she did a lot of sex ed teaching. Seeing the ovary here and the uterus helps us kind of understand what the anatomy is supposed to look like and how this egg and sperm can get together. And also, if we were to have something be awry, like a fibroid growth or endometriosis, a fibroid may get in the way of a baby that could grow in the cavity, or a polyp that's growing in our cavity could stop implantation potentially. Endometriosis could cause scarring and not allow our tube to be open all the way, or displace the ovary. So maybe the egg can't even meet to the fallopian tube. Various factors when we understand what the normal anatomy should look like. Next slide. So again, this is just a slide just helping us to understand ovulation. It's more about what we just talked about, which is that brain sends a signal to the ovary of FSH and LH hormone that helps us to grow a follicle to the state of ovulation. And so once that follicle is large enough, it will rupture open, release that egg, it lands in the fallopian tube. The other factor about that that's important is the whole time you've been growing this follicle, the follicle is releasing estrogen and progesterone hormone. Little amounts of progesterone hormone are starting to rise. The estrogen levels get very high. Then once that egg is released, your progesterone levels will jump up. Now, I've heard before concern about progesterone levels that are too low from patients. Oh, my level is only 6 or 7. The important thing to remember here is that the quality of your ovulation phase of your cycle, your post-ovulation phase of your cycle, cannot be determined by measuring the progesterone levels after ovulation, because progesterone levels will fluctuate over the course of several hours. So you may test it in one moment and it could be 7. You test it again, it could be 17. And it's going to continue to go up and down. As long as that level is 3 or more, you know that ovulation has occurred. And we just need to confirm that the ovulation has occurred for those of us that are concerned about our progesterone levels. Progesterone level measurements can be associated with normal or abnormal pregnancies once you're pregnant, and we can look at it at that phase. But prior to that, and just looking at that post-ovulatory period, not a lot of significance looking for progesterone levels that are 10 or 14, right? It's going to change. You just need to know that it's greater than 3. So again, this is depicting what the progesterone and estrogen are doing to the uterine lining in the cycle. The progesterone is essential to add good blood supply to that lining after the estrogen has kind of laid that base layer for us. And that progesterone is secreted from the follicle site, the former follicle site called the corpus luteum. And if there's no pregnancy there, the corpus luteum will fade away, the progesterone levels will drop, and this lining will shed in your menses. Next slide. Okay, so when the fallopian tubes are not functional, they can have an obstruction that can be secondary to adhesions. Interesting stories that I've heard are women who had a ruptured appendix. A ruptured appendix can sometimes lead to inflammation in the pelvis, and that inflammation as it heals is very sticky, just very sticky, and can cause that fallopian tube to get stuck to the bowel or get stuck to an unusual location that doesn't allow it to communicate with the ovary easily once that egg is released. Always something to consider. Sometimes these adhesions or that scar tissue can kink up the tube to not allow safe passage for that egg and sperm or fertilized egg to happen, right? Other things to consider. Tube can also be swollen. The tip can get blocked off and fluid can collect in that tube, creating a hydrosalpinx. That's a fluid-filled tube. Now, hydrosalpinx can reduce our chances of success in getting pregnant and may even be associated with miscarriage. So it's important to assess for the fallopian tubes, and your REI would do that for you. I previously alluded to endometriosis. It's the same concept as adhesions that would cause that kinking of the fallopian tube or displace the pelvic organs potentially. A hysterosalpingogram or a saline-infused sonogram, SIS, would be the best initial steps to determine the integrity of your fallopian tubes and their patency to determine if that egg and sperm can actually meet. Next slide. Okay. Great assessment here, your typical transvaginal ultrasound where we can assess the thickness of your lining and determine whether or not we're ovulating and if that lining is appropriate for an embryo transfer, if that lining is appropriate for timing your insemination, we can determine that. And so we like to see kind of this white line, they're labeling it the vanilla frosting, I just call it trilaminar. I haven't called it that. My colleague calls it that. It's pretty funny. That trilaminar appearance of the lining tells us that you've received an adequate amount of estrogen to your lining when we see that 3-line appearance. It's right before ovulation occurs. You have an adequate amount, your estrogen has done its job and thickened your lining. The next phase is progesterone coming into the environment, and you can see kind of that fading of that line there as the lining prepares itself for the potential of capturing an embryo, right? It becomes extra sticky, and that's what the progesterone assists in, adding good blood supply to that lining and making it plush for an embryo. Next slide. Okay. So when we assess the uterus to make sure that it is adequate for embryo implantation and for pregnancy, we do so in performing a saline sonogram or hysteroscopy. HSGs can also be used for that, or hysterosalpingograms, not always telling us the whole picture. Great sensitivity for detecting polyps with a saline ultrasound. And the way that's performed is that your reproductive endocrinologist and or her team member, oftentimes a nurse practitioner, would take a catheter, which is basically like a coffee stirrer straw, nice and thin. It's placed into the cervix, and about 3 tablespoons of saline are applied to the uterus. That allows for the walls of the uterus to distend and for us to see the cavity under ultrasound. This can help us diagnose polyps in the cavity, whether or not one of your fibroids in the uterus has dropped down into the cavity. It can also assess for any abnormal shapes to the cavity. Did you know that sometimes the cavity can have a heart shape where there's an indentation into it that can lead women to have miscarriages in their second trimester potentially, or make it difficult for them to get pregnant potentially? These can all be diagnosed with a saline sonogram in a 3-dimensional view in particular. And it's important to know that going into your next pregnancy, right? Uterine cavities that have limited space, we tend to want to limit multiple pregnancies, meaning having twins or more in the cavity, because that could be to your detriment. So we talk about that extensively, but this is all included as part of the workup. Also, if you have a history of pelvic inflammatory disease or prior DNCs from procedures done inside your uterus, scrapings, there could be scar tissue in your cavity that's preventing it from actually receiving good hormone signals and thickening up your lining. All these are important to assess. We'll typically counsel patients that because the uterus is getting distended with a little bit of saline, you may experience cramping similar to your menses. So we typically tell you take Motrin about an hour before your test to help you kind of ease into that. And I also provide heating packs for patients, and we use warm saline solutions so that you can just coast through. Next slide. All right. So going into more detail about those abnormal uterine shapes, right? The first shape that we're looking at is a uterus septate, right? You can see the flat top on top of the uterus. And again, this is if we're looking at your uterus sitting right in front of you. That flat top and that just little center that's coming down is just a uterine septum. And typically that we can resect those pretty easily in a hysteroscopic procedure. We use the tiniest little scissors. They almost look like Barbie scissors that go inside the uterus while you're under sedation and allow us to just gently trim away that tissue and open up your cavity to create one cavity. And that can be important for us for sometimes improving kind of outcomes, particularly in the second trimester of your pregnancy. The second image depicts the scarring in the cavity. And this can happen for women who have had prior infections to the pelvis. It can also happen to women who have had prior procedures to the pelvis, whether that's a fibroid removal or whether you've had a DNC in the past. This can cause the tissue inside the cavity become raw and it sticks to the other side and can cause that scarring. It's also procedures I perform pretty frequently. And it involves basically doing a hysteroscopy where we place a camera about the caliber of a big pen into the cavity while you're asleep. We place that into the cavity of the uterus. That fluid fills the cavity and begins to separate the walls. And an atraumatic scissor, like a scissor, again, the size of like Barbie scissors probably, is taken to those little adhesions, which almost look like cobwebs, and we're able to trim those away and open the cavity back up. And by doing that, the cavity can become more receptive to medications to thicken up the lining. Super important to get and be assessed for. A bicornuate uterus, this is a uterus that's actually got that big heart-shaped dip going down the middle. And this is typically not surgical treatment, right? For us, this means planning a pregnancy for you with typically one embryo, right, that will likely grow on one side versus the other for that pregnancy. The people with these uteri should not have twin pregnancies because the space in the uterus is limited, and it may increase your risk for going into labor early. It may increase your risk for miscarriage as well if that space is very cramped for one baby, but that's all counseling that we could do. And having a bicornuate uterus does not mean that we can never get pregnant or that we shouldn't be pregnant. It just means we have to be prepared for this pregnancy going into it. If you're interested, in terms of how these abnormalities occur, our uterus starts off in two pieces in our body. Sorry, Michelle, I'm almost done, I promise. I love the uterus. Our uterus starts off in two pieces in our body. And over the course of our development, it's supposed to come together and fuse and form one cavity. At any stage in that course of it coming together, a part can fall off and just have half a uterus, or the fusion may not completely take place. And so what you see with the heart shape is that the fusion hasn't completed yet. And that can happen at any stage in development, right? Okay, I'll stop there. I'll go to the next slide. Okay, sperm health. So super important, 50% of our whole equation. And I'm happy to say that Kindbody offers semen analysis at all of our Kindbody locations. And we have urologists waiting to talk to you about any abnormal result that you have, a urology team that's well equipped to help you with next steps and assessments, including blood work, scrotal ultrasound, a full in-person visit or virtual, however you like it. And so with sperm, once we do a semen analysis, so a semen analysis is typically done after 3 to 5 days of no ejaculation. A person produces sperm, a person with testes produces sperm, and we then look at that sperm under a microscope. We take one drop of that sperm sample, place it under our slide, and we assess for the concentration. We want to see at least 15 million sperm in that sample. We want to see at least 40% of that sample wiggling its tails and moving around. And we're also looking for normal shapes. So the normal shape for a sperm should be that round head, that thin neck, and that one tail that you're seeing. But abnormal shapes can include a large head, a small head, two heads, one tail, one head, two tails, a pin-shaped head, also known as a tapered head, and just an abnormal neck, right? What leads to this, what causes this can vary. Our urologist would talk to you about that. Any supplements you should consider adding. If the numbers are low, we can also consider like Clomid addition that you can be prescribed by your urologist to help improve total sperm number. And other factors will be assessed as to whether or not the fluid is thick or not at the time of ejaculation. We'll also assess for that and talk to you about factors that you can do, preventative measures for that going forward, right? So all that is to say, sperm is a critical component for our ability to conceive. It's very important to thoroughly assess it, and we don't leave that piece off. Next slide. All right. So even more detail about kind of male testing, sperm testing, persons with testis. We offer sperm DNA fragmentation testing. Now, this was a big one. And I venture to say that many of you who are on this webinar have probably heard about this before. So sperm DNA fragmentation testing can be offered for couples who could have had recurrent pregnancy loss, where we're having all these miscarriages, maybe chemical pregnancies. It may even be if you have unexplained infertility. No one's ever figured out why we're just not getting pregnant at all. I don't understand. Or the embryos we have in IVF are not normal, meaning not genetically balanced. And so DNA fragmentation testing can assess whether or not the DNA in the individual sperm are broken, and if they would benefit from going straight to IVF, where the sperm wouldn't be jostled like they would in insemination, where they'd be spun around in centrifugation. Or even if the sperm would be best gathered through a sperm extraction procedure. So that can be assessed. We can also assess kind of CAP score for the sperm, that ability of that sperm to be able to penetrate into the egg. We can assess white blood cells in sperm, that's your pyospermia testing. And we, of course, test male fertility hormones. I remember telling my husband this on our first date when I told him what I did, and, he actually was interested. That's how I knew we would get married. But we talked about, male hormones being the same as female hormones. It's just different plumbing. It just works a little bit differently. But men have FSH, they have LH, they have thyroid hormone, they have prolactin hormone, all the things that we test for women, and they even have certain degrees of estrogen levels as well. And all those are important to test what their levels should be. We don't have male levels as women. Males don't have female levels. So that's why it's important to test that and see if it's a factor in why we may have decreased sperm counts, right? We also do genetic fertility testing as well, where we can test kind of chromosome numbers for men, which may be a factor if we have a really low sperm count, right? We can do that testing. Infectious disease testing is done for all persons, and it's done for anybody who's doing IVF and has a partner, sexually intimate partner, where we screen for HIV, hepatitis B, hepatitis C, syphilis, gonorrhea, chlamydia. And we also screen for something called HTLV. And all of those are important to determine before the IVF cycle to reduce exposure to our partners. We frequently work with patients that have hepatitis B, HIV infection, in fact, and IVF can be a way to not expose the partner to the serum or the potential infectious disease. It can significantly reduce that risk of transmission. So I think these are all important things to note. And then scrotal ultrasound is, of course, offered for us to be able to diagnose varicoceles, or those dilated veins in the testis that can kind of reduce sperm quality. Next slide. So female testing, what are the required tests that we need if we're about to undergo IVF? What should we consider? Well, first things first, we always want to make sure just in general at baseline, your health is good, right? So we want to know you have an up-to-date PAP. That doesn't mean you need a brand new one. We just need to know that you've had an up-to-date PAP and that we have documentation of this up-to-date PAP, and that a physical exam with a breast exam was done within a year, typically, year or 6 months, depending on what the results were. That were within normal limits. And of course, I leave that at the discretion of your physician to determine if you needed one sooner or you need another one again to have before your procedure or pregnancy. We also require thyroid screening, and we also will test prolactin levels in many instances. Thyroid is extremely important because abnormal levels of thyroid hormone can lead to miscarriages in pregnancy. It can also cause cycle irregularities. And it's agreed upon by the Endocrine Society that if a woman is experiencing fertility issues or infertility, one should consider screening her for thyroid hormone, right? Infectious disease screening testing, we already talked about, should be included. We offer genetic carrier screening. I'm going to explain that a little bit more in detail, right? And that is optional for patients. It's not necessarily required, right? You can't force somebody to do genetic testing, but it is something that we like to offer patients to give them as much information as possible. We also check titers for immunity, including German measles, right? Rubella, measles and varicella, chickenpox before pregnancy. Now, this is critical to test, in my opinion, right? Now, once you're pregnant, you can't receive those particular vaccinations because they are live viruses that could potentially pass through the placenta and affect our pregnancy. So we have to know before we're pregnant if we require that vaccination. And typically we'll talk about, well, particularly for the rubella vaccine, waiting 4 weeks from your rubella vaccine before you're pregnant, right? And you can always work with your REI about timing IVF cycle and embryo transfer around that. Now, these vaccines, if you're just doing an egg retrieval, are not necessarily needed at the time of egg retrieval. It's more right before pregnancy we have to consider that, right? And we'll make recommendations for you for vaccination if you're found to be non-immune, but I would think that would be important to you as well. Next slide. Okay, so genetic carrier screening, what's that all about? So lots of screenings out there that are available through Natera agencies. We've got council agencies. Myriad is another one that's on the horizon. And then, so what this screens for, essentially, these carrier screenings, it's looking for kind of silent diseases we may have, right? That don't show any evidence of us having them. So for example, diseases you may have heard of, cystic fibrosis, spinal muscular atrophy is another one. Those are the two main carrier disorders by the American College of Obstetricians and Gynecologists that we recommend that we screen all persons for. It means that we may have a gene for this, but we only have part of that gene, right? And we have none of the symptoms. But if we were to get a sperm or an egg from a partner who also was a silent carrier for this disorder, there's a 25% chance that we would have a child affected with this specific disorder. So for example, cystic fibrosis. And so typically what we can offer through these genetic screens is that they'll screen you for kind of hundreds of diseases to see if you may be a carrier, and then we'll screen your partner for those same diseases to see if they may also be carrier. If you're both found to be carriers of the same disease, then you have the option of doing IVF, where one can conduct genetic testing on that embryo or on the embryos and determine which of the embryos have the disease or are carriers for the disease, and perhaps reduce the chance of carrying this on to the next generation, right? It's risk reduction. That's why we screen. And again, genetics are flawed. It's not 100% guaranteed that you absolutely won't have cystic fibrosis if the testing is negative for this. It just reduces our chance of having it if we're screened for the cystic fibrosis testing through this, and our partners also screened. Next slide. Okay. Other factors are BMI. So it's true, as somebody who struggled with her weight most of her life as well, BMI, obesity can impact our fertility negatively, right? We know that obesity can be associated with increased risk of miscarriage, reduced pregnancy rates, complicated pregnancies, and births. We know this. It's ideal to try to reduce our BMI to the best of our ability before pregnancy. We should understand what the categories of BMI are and where normal weight should fall. That said, I don't restrict, in terms of BMI, the patients I will see. And BMI, again, is only one part of the picture. It's not the whole picture of the patient, and should never be the sole reason why a patient is not treated or can't be considered to assist with pregnancy, right? And so I would encourage you that if you have questions about your BMI and how it pertains to your fertility, see your REI. Have that discussion and see what this looks like for treatment plans, getting us pregnant sooner. Many of us are also connected to weight loss specialists if that's something that you're interested in as well. Another factor is Zika. This is something that we always want to mention, right? That we know that Zika virus has been found in many parts of the world, especially where we tend to vacation. And so while we know there's no vaccination available for this, we do advise patients to follow the CDC guidelines, in terms of abstinence, or if not abstinence, then protected intercourse prior to conception, until you're out of the quarantine period of being exposed to Zika virus. So it's also something to consider. Next slide. All right. Nutritional supplementation. Actually, we do offer our own supplements for patients. We have our prenatal vitamins, we offer vitamin D, and we also offer coenzyme 10, CoQ10. Vitamin D levels, abnormal levels, can be associated with fertility issues. Prenatal vitamins are something we should all have on board, especially if we're considering pregnancy relatively soon. You should start that as soon as possible. Coenzyme 10 can help with kind of that egg quality and with sperm quality. I'll typically tell patients that they can start 600 milligrams a day and have their partners contributing sperm do 200 milligrams a day. Always check with your provider before starting any supplements, right? I don't have your whole history, so don't just use it. Just make sure you check with your reproductive endocrinologist. All right, but those are supplements that we can offer you as well. Okay, so things that you want to consider as you go on your fertility journey. What are your short-term goals? Do you want to get pregnant as soon as possible, or are you looking to just kind of preserve your fertility and then consider your options later, right? That's one question. And then what's the long-term strategy for how we're going to get there? How we're going to build your family? Do you want more than one child, or is just one child sufficient? This is important because it's going to help you with timing, right? If you're a 35-year-old woman and you're heterosexual and you're single and you want to be married before you start your family, okay, that's fine. Consider doing egg freezing at 35, because by the time you meet your partner, it may be another year and then another couple years before you actually start having your first child. And if you want 3 children, the first child at age 37 or 38 might be even difficult to get at that time. Definitely be difficult after you wait about 2 years to conceive again, to have that second child. And that third child may not even be a possibility in our 40s if we don't have some eggs that are maybe reserved for us for later use. So that's one scenario. And I actually just played out a scenario that a colleague of mine had, right? It's just all things that we can consider looking down the road. And then always remember, age is the main factor. I don't mean to keep harping on it. Trust me, the clock ticks over my head too. Keeping in mind our fertility will decline with age. It will. And even if we don't want to think about these things right now, at least consider having that conversation about, well, what is egg freezing actually about? Or what is sperm preservation about? If it's something that you may want to consider, if you're thinking about, again, gender changing later, it's good to have the sperm preservation on board earlier. Are you someone that's going to consider doing inseminations or IVF? Or maybe you want to bank those embryos instead. Kind of start to paint that picture. I know it sounds like it may be kind of far-fetched that you'd even have these thoughts, especially if you're single, you're not sure if you want a family yet, but I think these are more and more important questions that we want to start having. You know, we have the technology and the ability to do this now. These are things that, you know, when I was in my 20s, they weren't an option. They really weren't. They weren't a reasonable option, but now they are for so many people. And so we're trying to change the way we think about them now. Think about what fertility preservation looks like. It's more like an insurance policy for us than anything else, and something for us to look towards as having an option. Even if you don't exercise that option, that's okay. At least you had it as an option. Next slide. Okay, so what does it mean to be infertile and use that actual term? I think it's really gotten a negative connotation. I think it's somebody that's on a fertility journey is what I like to say, but technically speaking, from a medical standpoint, infertility is defined as the inability to conceive at age 35 after trying for 6 months or more with sperm exposure. Now, there are my dogs. I caution you about this, right? Because people tend to think about this as being, oh, well, we've only really been trying for the last 3 months. We haven't really been trying. Also consider those periods of time where you were exposed to sperm without necessarily trying, right? I have couples who weren't trying, but they haven't been using any birth control for years without a single pregnancy in that interim. I count that period of time, right? That was an opportunity with frequent intercourse where no pregnancy occurred. There may be something that's underlying at that point. For women less than the age of 35, it's sperm exposure for 12 months or more without a pregnancy. Next slide. Okay. So what is IVF? How does it work? Should you be scared? Don't be scared, right? It's pretty commonplace, more commonplace than ever before. And what I want to do is kind of dispel any myths around it and make you feel as comfortable about it as possible. So the way IVF works, just like the slide says, each month your body recruits a set of eggs from your ovaries to start growing and maturing. Think of your ovary like an onion, multiple layers to her. Your AMH, anti-Mullerian hormone, is determining how many eggs and follicles you have on each layer. And every month, if you're just ovulating normally with brain hormone talking, you're just releasing one egg from that batch and the rest of those eggs are dying off. In IVF, we want to access all of those eggs on that layer that otherwise would have died off by giving you injection hormone medications. These injection hormones are the same hormones your brain already makes. They are FSH and a form of LH hormone that talk to your ovary and get it to grow multiple eggs and follicles at the same time. These injections are typically used anywhere between 10 days, maybe up to 14 days. Every woman's response and cycle is different, right? And Kindbody physicians are really great at catering to what your body is doing in that moment and not just following a textbook. Next slide. Okay. So we will walk you through the process of how to do these injections. You'll be provided with videos for how we do these injections, how you can do these injections at home, how your partner can assist you with these injections. As you administer on a daily basis these injections, you'll be coming into office visits to have ultrasounds and blood work to make sure that you're appropriately responding to those hormone medications and that your follicles are growing appropriately. We want to stimulate your ovaries to do their best and grow as many of those available follicles as possible in that cohort. And okay, I like that they featured this on the slide too. We have tutorials and weekly virtual sessions to kind of walk you through this, where you can have your own questions and answers in those instances. But we're readily available with a really strong nursing team at each of our locations. Next slide. All right. So weekly med teaching sessions. We usually have them every Monday. They're anywhere between, so they're 6 p.m. Eastern and 3 p.m. Pacific time, where you can sign on and kind of ask questions and also go over how the medications should be administered. And, in terms of how the medications are administered, we'll teach you with these certain medications, there are powder vials that go into liquid vials. We'll show you how to get that liquid into the powder and how to dissolve that powder in your vial and draw up that fluid and use the appropriate needle to inject. We'll walk you through that. Next slide. Okay. So how does the egg retrieval work, right? Nothing to be scared of with an egg retrieval. I think that if you've ever had a dental procedure done, you can do an egg retrieval in a heartbeat, right? Egg retrieval, typically, after you've had that stimulation for about 10, maybe up to 14 days, at that time, you'll hear from your reproductive endocrinologist that it's time to take your trigger shot. This is the last injection that helps to loosen the eggs and mature those eggs in your ovary in the individual follicles and prepare them for retrieval. The day of the retrieval, you'd meet your anesthesia person, and that person would then administer for you typically propofol sedation. This sedation just puts you in a twilight state so that once you're asleep, your legs are placed into stirrups. An ultrasound probe is applied into the vagina, and the ovary is actually right next to the vagina typically. And it allows us to place a needle into the vagina directly into the ovary. And the ovary is filled with cysts. We're talking about an ovary that was on the average the size of a nectarine, now becoming the size of a navel orange, filled with cysts. And so that needle goes into each cyst and decompresses each individual cyst, and that fluid will pass out of the ovary and be sent into a test tube. Now, as I told you before, our embryologists are adjacent to us. They're right next to us as we're doing our procedures. These vials are handed off to our embryologist of your follicular fluid. Our embryologist takes that fluid vial, pours it out onto a petri dish under her microscope, and can see your eggs. And she'll call out to you, egg 1, egg 2, you'll be asleep, but it's for me. Egg 3, egg 4, egg 5. So I know exactly, or the reproductive endocrinologist knows exactly how many eggs we're getting over the course of the procedure. Typically, we can get anywhere between 10 to 15 eggs in a cycle, but this is dependent on your AMH levels and your AFC levels. Every woman is different. Some of us require multiple cycles in order to achieve 10 to 15 eggs, right? And you talk about that with your reproductive endocrinologist. There are times where we may cancel a cycle if we're not getting an appropriate response and look for a new approach to improve that outcome. There are times when we can do a retrieval and maybe we don't get as many eggs as we expect, but that's also an expectation that we set for you before the time of the retrieval, where not all of the follicles will have eggs, not all of those eggs will fertilize, and not all of those fertilized eggs will yield embryos, right? So there is a certain degree of loss. Next slide. So once the eggs are harvested and they're under the microscope for my embryologist, and she can find your mature eggs, we then will get our sperm and directly inject the sperm into each egg. In that process, we select out the best of the best sperm. We select out those sperm that are the best swimming, the best shapes, and we directly inject them into the egg. We typically expect at least 70% of those eggs to become embryos or begin the process of becoming embryos, right? We'll then assess, after those eggs have been injected, we'll then assess for embryos that are fully developed into what we call the blastocyst stage at day 5, day 6, and day 7. Why multiple days? Not all embryos have developed by day 5 and they need to go to day 6. Not all embryos have developed by day 6 and they need to go to day 7. But we typically will expect about 50% of those embryos to develop from that original cohort. Once they've developed to that final stage at day 5, 6, or 7, we can then do what's called genetic testing, pre-implantation genetic testing, aneuploidy, M for monosomy, or SR for structural rearrangement. Those can be performed at that time. And we're going to go to a slide to discuss how those biopsies are done. Next slide. So How do I know if my embryos are healthy? This is going to go into the genetic testing of the embryos. Before we did genetic testing for embryos, we used to just look at them under the microscope. We wanted to see as many plump, healthy cells in that embryo as possible to tell us that, oh, well, this embryo should be okay. That's only one of the factors that determine like general embryo health and its ability to implant and whether or not we'll be successful at the pregnancy, right? It's only one of the factors we think in the grand scheme of things. What you see here is a picture of a blastocyst being steadied on the left by a device that we use to steady the embryos. It holds by sucking on the embryo, holds it still. And the other device on the side is in the process of performing a biopsy on some of those cells lining the periphery of the embryo. So this embryo is called a blastocyst. You can see that there's fluid in the center. There's some cells lining the periphery, and you could almost make out a clump of cells in the center. The clump of cells in the center will become your baby, right? It's called the inner cell mass. And the cells lining the periphery of the trophectoderm, that's where we perform our biopsy. Those will typically become the placenta. The cells that we're gathering there will be sent off to our genetic lab while the embryo is frozen and left in the lab at your location. Those cells will be assessed for in pre-implantation genetic testing for aneuploidy and imbalance in chromosomes, whether you have too many or too few chromosomes at the specific locations. The goal of that is to determine, you could, from those cells, determine a screen for, Down syndrome, for example, or an increased risk for miscarriage if there are certain imbalances in those chromosomes. It could also, as kind of a byproduct, tell us about the presence or not presence of a Y chromosome, which leads us to know gender of the embryos if you're interested in family balancing of those embryos. Our goal in doing this genetic testing is to improve your chance of implantation, reduce your risk for miscarriage, and improve the chances of having a healthy birth or pregnancy. But it's flawed, right? Any testing is always flawed. It's not 100% guaranteed, but we go into it with that caveat as it's just a screening measure that may help our outcomes. Next slide. Okay, so for whom is PGT testing recommended? Well, if you're someone who's had recurrent miscarriages, you're a good candidate for PGT testing. If you're someone who's had multiple IVF cycles where you haven't had a pregnancy, this is a good test for you. If you're somebody with a history of family disorder, genetic disorder specifically, muscular dystrophy, Huntington's disease, if you have that and we know the genes where these are located, we can perform IVF and screen the embryos for these diseases. If both of you are carriers for specific disease, again, cystic fibrosis, you're a good candidate for IVF to screen this out of your next genetic line. And then also for older age 35 or more, considering the fact that we have more aneuploidies in general, we may be a good candidate for selecting out those embryos that may not give us success. And also if we have older age of our partner or sperm source, that's an important factor. I'd also add here family balancing if that's something that we're interested in. PGT can also help to select out or screen out those genders and improve the chances of having those specific gender children, right? And so going into more detail about how that genetic testing works, again, we're all endowed with a total of 23 chromosome pairs or 46 chromosomes. And this specific testing tells us if there's an extra one at location 3 or 14 or 15 or what have you, or if there's a missing one at that location. And it would let us know if we'd recommend using that embryo or not, or using an embryo that was genetically balanced, right? I tend to say balanced, not normal. Next slide. Okay, so again, we talked about the benefits of PGT just a moment ago that counts the number of chromosomes, determining the sex, and improving the chances of success. I personally enjoy using PGT for my patients and offering it to all of them that are interested. Next slide. So if you're someone who's a person who should not consider PGT, well, if you're not interested in the added expense, and expense can vary because there may be coverage with certain employers, right? And it's important to talk about what that cost would look like with one of our financial coordinators. If you're somebody who doesn't want an embryo biopsy, there's a small risk of injury to the embryo as with any procedure that's done to the embryo, but it's very small. For the most part, these are done across the nation and they do very well for the embryos. And then you also have to understand that the embryos must be frozen after we do the biopsy. So after we do the biopsy, the embryo is frozen until those results come back, which can take a week or up to 2 weeks to come back, depending on the result that we're looking for. So if you're somebody who's not interested in any of those things, then PGT may not be the result for you. Also, if you're somebody who is not interested in knowing about genetic outcomes for any of the pregnancies you have, or if there are ethical restrictions for you, then PGT may not be for you. And that's perfectly fine. I have patients that select not to have it, and that's perfectly reasonable. You can't force genetics. Next slide. Okay, so just setting expectations for typical retrieval and outcome. So let's say we do an ultrasound for you. You've been on ovarian stimulation medications for IVF. We see 12 follicles. Wonderful. Of those 12 large follicles that we see, maybe we'll get 10 eggs. Of those 10 eggs that we get, maybe 7 of them fertilize. Of those 7 of them that fertilize, maybe 2 or 4 of them grow that final stage of embryo development. And of those 2 to 4 that grow to embryo development, maybe none may be genetically balanced or euploid, maybe all of them will be. It varies, but we have to be prepared for any one of those outcomes at any one of those stages and prepared to pivot from there. Next slide. Okay, so we have different types of embryo transfers we can perform, fresh versus frozen. In a fresh embryo transfer, this happens just a few days after the retrieval. Your eggs are harvested. Once the eggs are harvested, that sperm is injected into those eggs and we grow out those embryos to the 5th day of development. In the meantime, you prepare your uterus with progesterone supplementation to compensate for your progesterone levels maybe being a little bit off from just doing IVF. And the embryo is transferred into that prepared lining that was prepared by the hormones your ovaries were creating. In a frozen embryo transfer, you are done with your IVF cycle, you've had a period and relieved your lining, and now we're suppressing your ovaries, not allowing them to make any additional hormones, and we are in control, you and your REI are in control of administering hormones to your lining to thicken that lining, specifically estrogen supplementation and progesterone supplementation, getting the lining to just the perfect amount of thickness. The image you see on the side is an embryo that's currently hatching out of its membrane and preparing to implant into the uterus. This is a great embryo to actually prepare for embryo transfer. Next slide. So why would we recommend a frozen embryo transfer, or FET, over a fresh embryo transfer? Pregnancy rates with frozen embryo transfers may be slightly better, and it gives a patient a chance to recover after neg retrieval where hormone levels may be really high, and then they're at their highest after neg retrieval. If you have ovarian hyperstimulation syndrome, you're not a candidate to have this embryo transfer done because it would aggravate those symptoms, increase your risk of hospitalization and miscarriage, so we don't typically recommend that. And a frozen embryo transfer also gives us a chance to kind of optimize that lining using those external hormones to get the right thickness, the right amount of hormone, and get that perfect window of time for the implantation. Also gives us an opportunity to do the pre-implantation genetic testing where the embryo is frozen while we wait for those results to come back the following week. Next slide. So this isn't a typical frozen embryo transfer calendar that we give to a patient. This is what you would get prepared for frozen embryo transfer, so you know which medications to take on which days. And then, you have the, light tan indicating progesterone injection. You know when the ultrasound is supposed to happen and when the blood work is happening, denoted by the black dot. And, basically ultrasound and blood work happen 2 times in a frozen embryo transfer cycle. First is the lining check, where we make sure your lining is thin, your ovaries are quiet right before you come in. I'm sorry, the lining check is actually the second one, that's your baseline. The lining check is the second time where we check that you've responded appropriately to the medication, that lining is beautifully thickened, and the hormone levels have appropriately risen, and your progesterone hormone levels are low, indicating that we haven't started our window of time when to do implantation yet. Next slide. Okay, so how does the embryo transfer work? Let's kind of dispel any of those myths. No anesthesia is needed for this, and there's no pain associated with it. We use, again, one of those almost coffee stirrer straws, if it was a little bit soft and flexible, to place into the uterus. And we need about 10 or 15 minutes to do the whole procedure from start to finish. Your embryo is thawed that day in a warm media bath and plumps up immediately after being frozen. Typically, survival rates for embryos are very high. And we'll pass that embryo into the catheter to the top of your uterus at the time of the under ultrasound guidance. And we'll also talk about, you can bring an acupuncturist with you of your choice to have there at the day of your transfer. That's totally reasonable. My location allows for that. You'd have to check with your reproductive endocrinologist. And then you want to make sure that you're acting as though you're pregnant from the moment you have this embryo transfer. You want to make sure that you're, hydrating appropriately, abstaining from alcohol or any recreational drug use, no tobacco use, making sure that you're sleeping adequately, right? Behaving as though the day of the transfer you are pregnant is ideal. Next slide. Okay, so I particularly like this slide because it's more, especially for me who had fertility issues as well, it was a big reality check for me. When we think about the success rates associated with IUI versus IVF, it's significant, right? Especially for someone who's been struggling to get pregnant for a long time. The biggest question I get is, should I go to IUI or should I just go straight to IVF? Can I go straight to IVF? Is anybody going to let me? Of course, we would let you, right? There are extenuating circumstances why persons are good candidates for IVF. And the thing to consider is, if you're ready, if that's what you want to build your family, and there are no health circumstances that would restrict us, but the fertility, or I should say the success rate for intercourse or an IUI per month using fertility medications is about 10 to 15% per month. When one compares with IVF in that same age group, and you get about 40 to 50% chance for success, it's significant, right? And if we add on that added element of selecting out certain embryos, we can raise that success rate to 50 to 65%. Very important. And then the next aspect of this slide that's also critical, putting more and more patients into the mindset of, you may need multiple cycles of IVF. Very few of us can have success with IVF after just one cycle, right? It's the reality. Many of us need 2 cycles and sometimes 3 cycles to get there. Keeping that in the mindset that your journey may require that for success, you can see the cumulative pregnancy rate that happens, right? For IVF success, if you've had 2 cycles, it now becomes a 60% chance of success, or 3 cycles, 72. All things to consider. And as we get older, we need more cycles to get more of those normal eggs, get more of those genetically balanced embryos. Keeping that in mind to be as realistic as possible. Next slide. Okay, so I can't emphasize this enough. Your journey is your own personal journey. It's going to have twists and turns that maybe your friends didn't have. Maybe they did. Maybe they had more. Maybe they had less. But that's fine. It's your personal journey. You just have to decide how you want this to go, right? You can decide how to build your family. Just be open to all the ways we can do it. It may be a donor egg. It may be a gestational carrier. It may be using your own eggs. It may be 3 cycles of IVF. But that journey will be your own personalized journey that you would create with your reproductive endocrinologist. Next slide. Okay, so we also have donors and surrogates available. Again, we have our own Kind EOS, where we offer our own donor eggs, where you can select out fresh eggs versus frozen eggs through our banks. You can look at the demographics of the donors, their screening process, and determine if this is a good fit for you. We have access to plenty of sperm donors across the nation that we work very closely with. You can also use a known sperm donor if that's something that you're interested in. Same thing for egg donors. They could be known or they can be anonymous through our banks. Embryo donation is also a characteristic. I just got an email about an embryo donation that's coming along. I actually just got that email recently. So we frequently partner with embryo donation programs to help patients as well. And we have gestational carriers available for you, as I said before. Next slide. Okay, so again, just an idea of the sperm donor. It could either be agency identified, right? Non-identified, so anonymous, or they could be identified sperm donor, somebody that you know that's personally contributing to the sperm. And we talk about how to connect you with an attorney to create a contract between you and that identified donor. We talk about clearances that we want them to have and from a psychological standpoint, making sure that they understand the implications of that donation. And we'd also check their specimen and infectious diseases for you beforehand to make sure they're a good selection for a donor for you going forward. Egg donors, we have, again, Kynenos, I mentioned, non-identified anonymous donation centers that you can find outside of us. You can also use known donors, family members, friends, fresh versus frozen eggs. And then we have embryos that can be donated from an identified or non-identified source as well that you can find on your own, or we can assist you with finding. Next slide. Okay. In terms of a carrier or the person who will serve as your house, you can choose to be yourself. You can have a surrogate. It could also be your partner that can carry your pregnancy as well. And we'll coordinate all of that for you. It's not something you'd have to second guess or think about or go somewhere else for. Next slide. Okay. Again, this just goes back to the same point. Your journey is your own personalized journey. You get to decide how you paint this picture. It is not specific to your friends or what you've heard before on social media. It is whatever you want to make it and the personalized plan that you create with your REI. Next slide. So in terms of your next steps, you can schedule an appointment at any one of our Kindbody locations. We should be getting close to that slide, Michelle. Is that the next slide where we're talking about where all the Kindbody locations are? Because I want to be able to access it. Perfect, right? You can select any one of these Kindbody locations to have your appointment, whether virtually or in person. Like I said, many of us have licenses all throughout the United States. If you want to see one particular person, we're happy to see you anywhere, anytime. We have plenty of appointments and availabilities for you just to begin just your initial workup. We have everything from simple workups that are pulse assessments. Pulse assessments are just, hey, I just want to know what my egg reserve is and what I look like on ultrasound. Sure, basic, perfect. And those are pretty inexpensive. So you can get that check, or I just want to know what my sperm analysis is and just get somebody to take my history, make sure there's nothing unusual there. Perfect. We have that for you too. Or more extensive. Hey, I have this in my family history. I'm really concerned about my fertility. What do you suggest I do? We have those visits available for you where you can talk to a reproductive endocrinologist, or you can talk to any one of our trained personnel. We work hand in hand with our nurse practitioners in particular, or highly trained in the fertility realm. So you have that option of selecting a visit at any time with us. And I do encourage you, if you came out for this webinar and you stayed on for as long as you stayed on, I'm certain that you're ready for the next step as being an appointment. So don't hesitate to make that appointment. Next slide. Okay, so we've got kindbody.com to schedule anytime. If you have a Kindbody benefit, you can activate that benefit through your employer. If you're not sure, let us know. We'll figure it out for you, right? Don't hesitate to contact us. Don't worry about the financial component. We have coordinators that can help you sort that out and figure that out with us. Okay. Questions and answers. I'm ready for you, Michelle.
Oh, you are amazing.
Too long, I know. Okay.
No, this is a big topic. So thank you so much for being so thorough. And thank you to everyone that was able to stay on the whole time. We do have quite a few questions, Dr. Balmir, but I'll, in the interest of time, probably just handpick a few.
Sure.
And then any that we don't get to, if everyone, or if you would like, please email that question to navigator@kindbody.com, or also you could DM us on Instagram, and we are more than happy to answer your questions there. So the first question we had was, does weight impact the success of IVF? And I know you talked about this, but I feel like it's something important to.
I think that's a great question, right? It can, where we have a higher BMIs from the beginning. What this can affect, higher BMIs can sometimes throw off our ovulation, right? That can give us cycle irregularities. But if we're talking about going into IVF, higher BMIs may require higher doses of medications in order to stimulate the ovaries. Why is that? Well, our injections are typically subcutaneous, meaning they go into the fatty tissue. If we have more fatty tissue, then it can have a hard time distributing and getting to those ovaries and stimulating them. That can be one factor. There could also be limitations at the time of that retrieval. If we have more weight, particularly on the pelvic side, on the bottom side, it could be harder for our ultrasound to be able to access those ovaries and get there safely to get to your eggs. But what I would tell you is every situation is different. And each of us at our different centers have different kind of limitations in terms of what BMIs we can and cannot do IVF for at the moment. Usually the restrictions have to do with the anesthesia that you receive at the time of the retrieval. In order for you to receive a sedation anesthesia in our ambulatory sites, right? These are sites that are not attached to hospitals, and to make it as safe as possible for you, we want to make sure that there's no restriction to your airway. And at certain BMIs, there may be specific restrictions to the airway that could compromise you at the time of the retrieval and complicate, like, life-threatening for you, right? And so to reduce that chance of that happening, that's why we have kind of those BMI restrictions. But I have a pretty high BMI cutoff for IVF at 43, and I work with patients that have BMIs of 50, 60 even, right? Or even higher, right? We still have conversations. We still talk about, well, how do we get to this goal? And what can we do in the meantime? What can we cycle with in the meantime? What can we try in the meantime, right? What are the other health factors that are surrounding us, right? A BMI of 44, otherwise healthy, no diabetes, no hypertension, everything else looks great, you're taking care of yourself, we should still be able to pursue pregnancy, right? So there are different factors at play here and what we can work with within there. So I would encourage you that if BMI is your only concern, please schedule an appointment with your REI, schedule an appointment with me. Let's have a conversation. Let's just talk about where we go from these next steps. Don't let that be the thing that holds you back.
Great. That's a great question. I did not mention before, but I just want to mention this now in case anyone has to hop off. There is going to be a survey that it will pop up on your screen when you close out. If you could fill that out and just let us know if you want to schedule an appointment, then we will know to reach out to you tomorrow. So I just want to mention that that is going to be popping up, and hopefully you can fill that out. Another great question that came through, Dr. Balmir, is, do you typically experience pain after egg retrieval?
Great question. And I would tell you that it's a spectrum, right? Some women experience no pain whatsoever. But did I really just do this procedure on you? You didn't feel anything. And some women experience like some cramping and some discomfort, like they're getting a period. So it can vary, and it depends on like the difficulties of your retrieval and some other medical history aspects. If you're someone who had an egg retrieval that may have had to go through the abdomen, right? There are times when we have women that have ovaries that are stuck just under the skin of their belly, believe it or not. And the quicker access, rather than going through the vagina to get it, is going right over top the skin and aspirating those eggs, right? I've done those retrievals before. And in those instances, you may have more discomfort in that area. But pain is definitely a marker for us. You should not have unbearable pain after retrieval. There's an issue there, right? That needs to be evaluated. Is it bleeding? Is something else going on? That should not occur. Should you have some cramping and some mild discomfort? That's typical, right? And it's typically managed by either IV Motrin medication, oral Tylenol, oral ibuprofen. All of those things can manage it. And postoperatively, we'll make sure you're comfortable before you go home. I personally have had an egg retrieval done. We froze eggs when we were in training, myself and my colleagues, just to learn about the experience of what that's like as a patient, and also because we were all very still single. And in that experience, I could tell you, you don't recall that you had a needle in your vagina. You don't get the sense, the biggest sense that you get is more of like this fullness in your pelvis, knowing that your ovaries were just stimulated and they're probably just weightier, more pendulous, right? So that's one feeling you can have, and feeling like you're getting a period but not really coming, or just very crampy, but typically alleviated by over-the-counter medications at home. Rarely are narcotics required, like oxycodone, after your procedure. That's pretty rare.
Okay, great. I'm just going to wrap up with one more question. There are so many other good ones, but I just want to kind of pick this one because I'd like you to highlight what the success is in your opinion using Kindbody versus other healthcare providers.
Okay, that's actually a really great question, right? Because I've kind of run the gamut. I've been to academic practices, I've been to private practices. I think the success rate for Kindbody is really great. I think it's high. I also consider the fact that Kindbody doesn't turn away patients, right? We don't cherry pick patients. I'm not suggesting that my competitors do at all. I'm simply saying that it's all comers, all persons. And when you take that into account, when you're taking into account that, all age groups that you would see a visit for, that you're taking into account that you're not looking necessarily at just the egg reserve as a factor and taking into account this whole picture for the patient and what's offered. I think that's what's unique about Kindbody, right? All comers and great rates. All persons who want to try to expand their family and want to do it in a different way, right? Have a personalized plan. That's what makes Kindbody unique in their success. It's these personalized plans. It's all persons, if that answers your question. So yeah, I do think that's very unique.
Yes, absolutely. Well, this is wonderful. Thank you so much again for everyone who spent their night with Dr. Balmir, and we hope this was informative. Again, don't forget about that survey at the end, and then email us those questions because we are happy to answer them. Is there anything you want to say, Dr. Balmir, to wrap up?
I'm just about to close off my chat, and I saw one question pop up that actually comes up pretty frequently. Patients with outside labs from other facilities,
Oh,
they have to
yes.
repeat them again and go through that expense or that torture if you had like an HSG or something. I will speak for my facility specifically. As long as the labs, whether you had a screening test for hepatitis B or HIV done at Quest or at my office, it's the same lab result. As long as it's done within an appropriate time frame, those labs are still applicable and they can still be applied. Any provider would want to see your name and date of birth on a copy of a sheet that has those lab results to validate them. And the nice thing about Kindbody, a nice feature, is that you can just take a screenshot of it and upload it to your portal, and boom, there it is. You don't have to go through kind of like the rigmarole of like, fax it from my doctor. They didn't get it. They didn't get my fax, get my response. Oh, that's such a hassle. Even for me, I can't stand that for doctors' offices. It's a headache for getting my records across. So just being able to take a screenshot of something with your name and date of birth on it that has a result and the date at which it was done, that's enough for me.
Excellent.
Okay.
Well, thank you everyone again, and we hope to see you soon. Thank you, Dr. Balmir, again. You're just a wonderful educator.
I appreciate everybody being here. Thank you for listening to me kind of prattle on about the things I love. I look forward to seeing anyone, anytime, lots of licenses, so you can check in for that.
Have a great night, everyone.
Take care.
Bye-bye.